morning, everybody. We are going to have a very interesting sessions, non-communicable disease, and we have three speakers. We will be speaking on online. Professor Shanti Mendis, Dr. Devaki Nai, and Professor Nawal Vikram from India. So first of all, I'd like to invite Professor Shanti Mendis. She's my mentor actually. When I was in register, she's my consultant in Peradeniya. Madam, over to you.
Hello. Can you hear me?
Yes, madam. Yes, can hear.
Okay. Thank you, Mr. Chairman, for your kind introduction. It is a great pleasure for me to join the annual academic sessions of the Sri Lanka College of Internal Medicine on the theme Integrating Expertise for Optimal Patient Care. Thank you very much for the kind invitation. Let me share my slides with you first. There we are. So your theme is integrating medical expertise for optimal patient care. And in this context, I will speak to cardiovascular disease risk assessment in Sri Lankans. Where are we? Let's see what it is, why we consider that it is rational to do the assessment, how it could be done even in resource-constrained settings, and in Sri Lanka, what is the place? You all know, as specialist physicians, that in Sri Lanka, 80% of deaths currently are due to non-communicable diseases. Heart attacks, strokes, chronic kidney disease, complications of diabetes, chronic respiratory diseases, and cancer. Now, these diseases are not due to one single cause. We know that behavioral risk factors like unhealthy diet, physical inactivity, harmful use of alcohol, air pollution, all these contribute. And then we have tobacco use, which is a major risk factor. And as a result, we have metabolic derangements like hypertension, diabetes, high levels of lipids, and obesity. And all this is then also controlled and engineered, I would say, by age, gender, and even the genes. So you see that non-communicable diseases, cardiovascular diseases, they are not due to just hypertension or just hyperlipidemia. And you know very well that the major cause of diabetes, morbidity, and mortality is cardiovascular disease. So let's remember that and recognize that. Now, cardiovascular risk associated with raised blood pressure, blood cholesterol, and blood glucose is a continuous one. This is very important to recognize. We doctors, we use arbitrary cutoffs saying, okay, this is hypertension, this is normotension. Hyperlipidemia, the cutoff keeps changing. And for glucose, we have a cutoff. But what is important to remember is that the association, the risk associated with these metabolic conditions, the risk is continuous. However, benefit of lowering these metabolic risk factors with treatment, particularly drug treatment, must always override harm. And that happens only at a certain level, which is determined by randomized controlled trial evidence. So just because a pre-hypertension category has been created for a variety of reasons doesn't mean that we must rush into treating everybody with borderline blood pressure with medicines. There are non-pharmacological measures which can be very effectively used for those categories. So drug treatment is important, but as internal medicine specialists, you must also realize that it is unethical to promote unnecessary use of medicines because there are profit motives behind the sale of drugs. That is a fact. And there's nothing wrong with that either. But as doctors, we have our ethical responsibility. So the rationale of using cardiovascular risk is that an individual who has multiple risk factors, even if each is only moderately elevated, that person is at an overall higher risk than someone with a single risk factor, which may be very high. And targeting treatment at people with higher risk, that leads to a greater number of events being avoided because the relative reduction of risk would be applied to a higher baseline risk when you take the treatment decision. So that is the principle or the rationale. It's a multifactorial risk we are talking about. We are not talking about a single risk factor most of the time. And if you take the populations in the world, let's look at Southeast Asia, where you can see Sri Lanka in the fourth bar from the top here. You can see this is the risk levels. The majority, like 60% of the people in the population, they have a risk which is around 5% or less. Then the rest, about 40%, if you take the adults, they have a higher risk based on the risk factors that they have and also the age being a very, very important risk factor that drives the cardiovascular risk. And this is one of the difficulties that Sri Lanka faces because Sri Lanka has a very fast, rapidly aging population. And you can see that in that bar, about 30% have medium risk, another about 5 or 6% they have higher risk, and a very small percentage have a risk around 30% or more. But the fact is that the majority of cardiovascular events, heart attacks and strokes, occur in people who have moderate risk, and a certain number also occur in people with very high risk, with very high blood pressure or very bad diabetes. But the fact is, we need to get at the people who are having moderate risk because of the elevation of a number of risk factors, not very high, but still contributing to the cardiovascular risk. So as doctors, it is not easy in a busy practice, and all of you have busy practices and busy clinics, to differentiate and make the risk prediction or the risk assessment without charts. Take subject X and Y, both are 60 years, both have a blood pressure 160/98, which is considered hypertensive, cholesterol level 5. One is a smoker, the other one is a non-smoker. And purely because when you take all of the risk factors together, the additional risk, total risk, becomes more than 30% for subject X and 10 to 20% for subject Y. So you can see that subject X obviously has a higher risk of cardiovascular events. And as specialists, although you are very eminent and very educated and lot of expertise and experience you possess, in a busy clinic without a chart, it is somewhat difficult to arrive at the correct risk level. And that is why the cardiovascular risk-based management is promoted by the World Health Organization. We have several different guidelines which give very simple protocols. This approach is implemented now in more than 70 countries. This is one of the first products that I developed when I joined WHO. At the time I joined WHO in the late 1990s, there were no cardiovascular risk charts for the developing countries. They were there only for the rich developed countries. And then we took about 6 years to develop the first set of cardiovascular risk charts. Since then, of course, there have been many other developments. Now, in 2007, we released the first set of charts, and that work started in late 1990s. It took a lot of time. Lots of groups of experts from different parts of the world worked on it. But now in 2019, those charts we have revised using improved computing, improved statistical methods, which have allowed pooling of global data sets. And the current charts, therefore, are more accurate risk prediction tools. And they are available for all the populations. And this details of this exercise can be found in the Lancet. I have given the reference in the slide at the bottom for those who are interested. And the way it was done, we started this exercise in 2015. First of all, the model was derived from the emerging risk factor collaboration data, which has 85 cohorts. And then the model was recalibrated for 21 global regions. And on the right, you can see what kind of data sets were used for that: global burden of disease study estimates, NCD risk collaboration estimates, etc. And finally, the third step was validation. For validation, we used external cohorts. 19 cohorts were used from different places, from China, from Iran, from the United Kingdom, from the United States, and they have also been externally validated. So the new charts are very much more accurate for predicting risk. And they use laboratory-based variables as well as non-laboratory-based variables, recognizing that in most developing countries, you can't always do serum cholesterol and even a blood sugar in primary care. And this is changing for some countries, fortunately for Sri Lanka as well. But if you cannot assess the blood sugar, assay the blood sugar or the blood cholesterol, then there are charts that do not use laboratory-based parameters. They use the set below, that is age, sex, tobacco use, systolic blood pressure, and body mass index. The laboratory-based one, I will show you in a minute, those charts, they use, in addition to age, sex, smoking, systolic blood pressure, presence or absence of diabetes, meaning you need to get a blood sugar done, and a total cholesterol assay. So here are the new charts, and this particular chart can be used for Sri Lanka. You see that there are charts for diabetic people and non-diabetic people. This is the first thing you have to choose. After that, you have to choose whether the patient is a man or a woman. And then you have to factor in the age, smoking status, systolic blood pressure, and cholesterol. And there you have the risk. And the risk level is given as a number in the square. So these charts are, in fact, an improvement on the previous charts, and they are more accurate. And you can see there are several different categories. And this chart is the non-laboratory-based chart, which can be used very usefully for Sri Lanka in healthy lifestyle clinics. I think we have like 900 of them by community health workers. It is extremely important to remember that specialist physicians, they have a very important role to play in controlling the NCD epidemic, but the most important category are the primary healthcare workers. Unless we make use of our primary healthcare system to the full, Sri Lanka will not be able to control the NCD epidemic. So we need to really, really pay attention to what is happening in primary health care. So here you see, we don't use blood sugar or cholesterol. We are using age, we are using the systolic blood pressure, and we are using the body mass index. And still, you can come up with a fairly accurate assessment of risk. The only difference between the 2007 charts that we developed first and the new charts in 2019 is that the risk levels, there is a difference because we found more data all over the world which enabled us to do that. So you have the green category, which is risk less than 5% in the 10 years for fatal and non-fatal events. And the very deep red maroon color is more than 30% risk, whereas in the previous charts, we had categorized that as 40%. That's the only difference. So you have risk levels less than 5%, 5 to 10, 10 to 20, 20 to 30, and above 30. And depending on this risk level, you can make a decision about giving drugs or giving non-pharmacological treatment. How often should you be following them up? Because we know that the higher the risk, the higher the event occurrence. Now, we doctors, we have an ethical and a moral responsibility to do no harm to patients, and remember, please, also health systems. And we have an ethical and a moral responsibility to protect the health system of Sri Lanka, which is an excellent one, and to ensure that limited resources can save lives. And I will show you, Sri Lanka has severe limitation of resources. And at the same time, industry, pharmaceutical industry is a very, very important partner in medicine, but it's a fact that industry promotes single risk factor approaches and guidelines. They influence doctors and NGOs through grants and incentives because it's a fact again that more drugs are sold means higher profit. But it is our responsibility to do what is evidence-based, do what is sustainable, and do what helps patients and do what improves health outcomes. So let's look at the situation of Sri Lanka. Can we behave like the USA? Look at the numbers. We are a middle-income country, and high-income countries like the US, UK, their per capita expenditure is $5,000 per person. Low-income countries spend only $40 per person, and middle-income countries, they spend something like $80 to $400 or $500 per person. And for Sri Lanka, the last time I checked, it was something around, I believe, $250 per person. Anyway, the fact is that we spend very little per person when it comes to health, and we cannot sustainably, without destroying our health system, follow what is going on in very rich countries. And it is not necessary either. And look at how much Sri Lanka is spending on health. Our out-of-pocket expenditure is extremely high. It's 50%. Government domestic revenue, 42%. And you know that very small percentage of Sri Lankans are covered with health insurance. And to make it worse, government spends only 8% on primary care, 48% on secondary care, and 44% on tertiary care. We really need to see that the primary care investment is at least doubled. And Sri Lanka has seen a decrease, not an increase, in current health expenditure as a percentage of GDP from 4.25 in 2000 to 3.89 in 2017. Whereas globally, we can see an increase from 5.4% of GDP to 6.3% in other countries. So we are not doing very well in terms of investment in health. And the current budget figures I used to develop this slide, for the health ministry, 2020 allocation was 255 billion, 2021, 301 billion, and 2022, it's going to go down to 234 billion. Whereas you can see the figures for the defense ministry, it's almost double. And we have to take note of the fact that Sri Lanka has to pay debt. We have borrowed large sums of money from other countries and from various banks and funds. And we have a debt payment, 5 to 6 billion in the next few years. And our foreign currency reserves, only $2 billion US dollars, 300 million in gold, 1.7 million US dollars only is available to pay debt. And how is Sri Lanka going to do this? I wonder and I worry. And we must recognize that Sri Lanka has difficulty with resources. So risk prediction charts complement integrated guidelines, which is your theme, integrating expertise to improve patient care. And charts, the risk prediction charts, they allow you more accurate assessment of risk and events. And in order to use the limited resources, particularly in the public sector, particularly in primary care, you need to know who are the people who are at higher risk. And then you can make very, very sound drug treatment decisions. Who should you give statins to? Who should you give antihypertensives to, etc. And risk charts also can motivate people to manage their risk better. And you have a wonderful tool in risk prediction charts to engage primary care workers. And I really, really hope that the College of Internal Medicine Physicians will focus also on educating the primary healthcare workers and collaborating with them and with the ministry in this task. What about evidence? I have listed here a few. I'm not going to go through them because we don't have the time, but those who are interested, you can read them. There's plenty of evidence that a total risk approach, instead of a single risk factor approach, like just looking at hypertension or dyslipidemia or diabetes alone, is much more cost effective, makes the health system efficient, and it translates into better clinical outcomes. So when you take a group of patients that come to a primary care clinic, it's not complicated to use cardiovascular risk assessment and the total risk approach, because you know that there are only three groups of patients who come. The first group are the majority, blood pressure between 140/90 and 160/100. And this group, unless the cardiovascular risk is higher than a certain level, which the ministry and you all should decide, they should be first given non-pharmacological treatment before just giving them drugs, particularly antihypertensives, which should be used, of course, if people have blood pressure 160/100 or above. They need medications as well as non-pharmacological treatment. There is a category of people who have a blood pressure 140/90 and 160/100, but with other risk factors. Therefore, the chart will tell you they have a higher risk. They also need medications together with non-pharmacological advice. And we know that those who have a risk about 20% at least should be given statins, because evidence shows that events are reduced by adding statins to this particular group. Then you have group 3, that is the high risk group. And this group, if you wish, you could assess the risk. If you don't want to assess the risk, even that would be fine. These are the people with established cardiovascular disease, with very high elevation of a single risk factor, where you have to refer them immediately to the next level, and people with long-standing diabetes and chronic kidney disease. But even they would benefit by assessment of risk and showing the patient, and the doctor is also then compelled to check tobacco use, which sometimes often is neglected and forgotten as a major risk factor. So to summarize, why use total risk approach to prevent cardiovascular disease? You have lots of reasons. The most important, I believe, is that it improves, there's clinical benefit, it improves patient outcomes, because you look at all of the risk factors which go to produce the heart attack or a stroke, not just blood pressure, not just lipids. And it is very cost effective and affordable for Sri Lanka. And don't forget, we have very high levels of risk factor prevalence. Our hypertension levels are 22 to 23%, diabetes is increasing, obesity levels are increasing, all the risk factors are going up, and our population is aging. And WHO recognizes that this is a best buy. In other words, when you invest money in this approach, total risk approach, you have a very good return by prevention of events. It also improves health system efficiency by preventing duplication. because in primary care, it is senseless to have several different programs for each risk factor. It motivates patients, it helps you to engage primary care physicians and non-physician health workers, and you also then pay attention to all the risk factors together. So, in conclusion, should Sri Lanka blindly follow rich countries and establish single risk factor programs in primary care? Absolutely not. We cannot afford it. They are not sustainable. And in any case, it is not necessary. Of course, at tertiary care level, we need specialized single disease programs. They are justified for attention to complex cases as well as for research, etc. So to prevent heart attacks and strokes, what Sri Lanka needs is an integrated program which uses cardiovascular risk assessment well established in primary care and secondary care using cardiovascular risk assessment. And it is only then that you can do justice to the theme of your conference, integrating medical expertise for optimal patient care. Thank you very much for your attention. I'm happy to take any questions if you have.
Thank you very much, Madam, for that informative lecture. Actually, the Ministry of Health Sri Lanka has introduced the total risk approach about 10 years ago. And even though some reluctance at the beginning, now it's being accepted more and more. If you don't mind, we would take the questions at the end of all three presentations. If you can wait with us till the end of this symposium, we will take the questions at the end.
Thank you very much.
I would like to introduce our next speaker, Dr. Devaki Nair, who is the consultant chemical pathologist and clinical lead for clinical biochemistry at Royal Free Hospital and North Middlesex University Hospital, United Kingdom. She's going to talk to us on South Asian dyslipidemia, the difference. All to you, Dr. Nair.
Sorry. I hope my screen is shared.
We can hear you, Dr.
Hello?
Nair. We can hear you.
Can you hear me?
But we can hear you, but your screen is like, we can only see half of that.
You can only see
Yeah,
half
now
of
we
it.
can see it clearly, yes.
Okay, thank you, thank you. Thank you for inviting me to give a lecture on the South Asian dyslipidemia at your esteemed SEMCON conference. I was hoping that I would join you in person. For circumstances are difficult. We'll have to do virtually. I would have loved to be there among you, to be able to meet some of you and exchange ideas and collaborations. Thank you again for the opportunity. What I'm going to do is to go through some of the differences, and I would say, are there differences? You know, we talk about differences. Are there any differences at all? So who are South Asians? South Asians are defined both by the WHO and other places. Are those people who moved, or living in these countries, Bangladesh, Bhutan, India, Pakistan, Nepal, Sri Lanka, and that may include Afghanistan and Maldives as well. So this is the definition you see in the medical literature when they talk about, the South Asians. And it is because it's based on the data that is available on dyslipidemia and so on. And, when I look at where I come from, where I've lived for more than 30 years, you can see there are many, many British Asians, and 4% of the population of the United Kingdom is, British Asians, which is mostly South Asians, and 50% of the UK's non-European population is also South Asians. And how did this interest in what is the difference between the South Asians and others come up? It is because the migrants of the South Asian origin are at the higher risk for death due to cardiovascular disease, because that has been seen in many of the countries where they have moved to. They're the highest risk for diabetes due to the increasing body weight and central abdominal obesity. And high blood pressure and kidney disease are also common among the migrants of South Asian origin. And the uptake of the health expenditure in terms of this is quite high in some of the countries where we have migrated to. And this has opened up these questions. Why are we at a higher risk compared to other populations? And if you look at deaths due to acute myocardial infarction in South Asians, occur 5 to 10 earlier than the Western population. And it's that, again, the high risk for acute myocardial infarction in South Asians is in the young age. It's determined by high levels of conventional risk factors. They collectively explain 86% of the acute myocardial infarction risk in South Asians. And protective lifestyle factors such as the leisure time physical activity and regular intake of fruits and vegetables, particularly lower in the South Asians than the Western population, while the harmful risk factors such as the dyslipidemia are higher in South Asians. So there are differences, but the differences can be managed. So what do you see in the South Asians? Most of us in the South, who come under the definition of South Asians, have a low HDL level. We have high triglyceride level. We also are known to have an elevated lipoprotein (a), which is a prothrombotic factor and an independent risk factor. And one of my colleagues used to say that it may be that lipoprotein (a) is protective because we need in the past, in the olden ages, we needed that thrombotic potential because we lived in places where insect bites, snake bites, and all that. We needed that that thrombotic potential, and that maybe that elevated lipoprotein (a) is an evolved beneficial one, but this is not so in the present age. It increases one's risk for cardiovascular disease, and it is seen as an important risk factor in the South Asians. And we know that now we use more of the non-HDL cholesterol as a marker for high risk for cardiovascular disease in terms of dyslipidemia. And the reason is the non-HDL consists of all the atherogenic lipoprotein, including the harmful VLDL component, the lipoprotein (a), as well as the LDL and the intermediate density LDL. And so on. So the non-HDL is a better predictor. And if you look at the South Asian profile, which is a low HDL and elevated triglyceride, probably the difference we see in the South Asian dyslipidemia is an elevated non-HDL cholesterol, and therefore that becomes a target and a threshold for us for treatment. Elevated apolipoprotein B. And, I heard Professor Mendes talking about, whether we can afford all this apolipoprotein B is not used for routine measurements to assess the risk. And even in UK, which, spends a lot of money on healthcare, apolipoprotein B is not available except in tertiary centers where there are specialist lipid clinics. But it does give you that, the edge over measuring LDL, it also includes the VLDL part of the part of the lipid, the lipoprotein, which increases the risk for cardiovascular disease. But elevated non-HDL cholesterol is as good as elevated apolipoprotein B, and that is cheap. You only have to measure total cholesterol and an HDL cholesterol, and you can get to calculate the non-HDL cholesterol, because it's a calculated value from total cholesterol, take away the HDL cholesterol. So with just 2 measurements, you will be able to get as much as what you want from the apolipoprotein B measurement. In countries like India, Sri Lanka, etc., cost is a problem, and access to healthcare is difficult, and we want to extend the prevention to a larger population where we will not be able to measure these expensive measurements. Diabetes, again, another important risk factor with elevated glycated hemoglobin, and as well as glucose. Other genetic causes can be considered: familial hypercholesterolemia, type 3 hyperlipidemia. I wouldn't be going into the details of that, but we need to remember that in our population as well, that the genetic causes should be considered in a small proportion of the patients, and the prevalence is recorded as 1 in 500. I don't think we know how many, what is the prevalence of familial hypercholesterolemia in countries like Sri Lanka and India, because we don't have the prevalence studies as we have in other countries, and type 3 hyperlipidemia as well. And these can also be more because of the founder effect, because we were with small countries, due to the marriage within the community, etc. These may be high. And one of the observations I have from the experience in UK is that lipoprotein lipase deficiency is higher in the South Asians, and I do have quite a few patients of Sri Lankan origin. So the genetic causes, should be considered as well when we talk about dyslipidemia, but I wouldn't be going through that in detail. So looking at the INTERHEART study, which was the one which included most of the South Asians as for the comparison, and you can see the elevated ApoB and ApoA1 ratio being high in South Asians. The diabetes is high, hypertension is high. But we don't have a high smoking level as in the Western population. We do have problems with healthy eating, and probably alcohol, although it comparably to the Western population, it's less, but it's just still high for our population. And what has also been shown that, unlike the Western population, the alcohol has not been shown to be beneficial for cardiovascular health, at least in the South Asian population. And psychosocial stress is always another factor being considered. So the risk factors which you consider, the atherogenic risk factors and the thrombogenic risk factors. And if you look at upstream, urbanization, industrialization, globalization, and as Professor Mendes explained, the population aging is an important risk factor that is affecting some of our countries. The public policies, whether we can afford to roll out prevention programs, socioeconomic status, education, etc. Then the behavioral factors like unhealthy diet, psychosocial factors, sedentary lifestyle. And if you look at the physiological one, dyslipidemia, obesity, hypertension, and diabetes, all are interrelated, and we cannot take dyslipidemia away from, from these total risk assessment, just as Professor Mendes, explained in the previous lecture. And we also have South Asians also have a thrombogenic potential, especially due to diabetes, and fibrinogen levels are high, platelet size and function abnormalities, the endogenous fibrinolytic capacity is reduced, lipoprotein little a is increased. So these are the differences which we have. And I would say, are we different? We are not different. If you look at the Western population and compare the diabetic population, it's not very different from the dyslipidemia, what we see in our population. And the diabetes is a major epidemic among the South Asians. And you can see that South Asians have 5 times more diabetes than compared to the other population. And if you look at the continuum of the risk in diabetes, impaired glucose tolerance, even when they have impaired glucose tolerance or insulin resistance, you have low HDL, high triglycerides. It's the hallmark of of the South Asian population, that reduced HDL and high triglycerides and mild to moderate hypertension at the very early age, and the ongoing hyperglycemia exacerbating these causes and causing complications. So I think the difference is that it's the prevalence of diabetes and the insulin resistance in these patients. So if you look at this table, which looks at the Masala study as well as the MESA study in America, and if you concentrate on the BMI, and we would always say that we are fatter compared to the other population. But if you look at the Masala South Asian population, yes, we are slightly higher in BMI compared to the Chinese American, but the white are as big or bigger than us, and the Hispanic and the African Americans are bigger. So that is not a problem. And we also think that we eat a lot more than we need. Yes, that is true, that we may be consuming high energy food much more than needed, but not much more than the other population. So even the energy kilocalories per day is not that significantly different. And you would see that the education is not we're not behind when you compare the population who have moved abroad. But this is the immigrants. That's where you can do the comparison. So that doesn't explain that. And if you look at the risk of coronary artery disease in the South Asian American population or the UK population, this is quite a revealing one. Compared to every other Asian population, South Asians have a very high risk for cardiovascular disease, and that is well known. So we conducted several health screens in temples, because I have an interest in South Asian heart disease prevention. So we conduct cardiovascular risk prevention camps in temples and mosques, etc., because people don't the uptake of preventive services among the South Asians is less than the Caucasian population. They don't pick up preventive services. So this is a hard to reach community, and so we go to the temples. And you can see that if you look at the cardiovascular, we have done around 2,000 patients. We go on Saturday or Sunday to these temples with the little machines, which can measure total cholesterol, the blood pressure machines, etc. A team of us go there, and people in the community help us. And you can see that 30% of that population have a blood pressure of more than 140, 26 have a diastolic blood pressure, which is high. And if you look at the lipids, 37% had a high cholesterol. HDL cholesterol is 1 in 3 of these patients had a low HDL cholesterol, and 14% of these patients had a highish HbA1c in the insulin resistance or the impaired glucose range, and 3% were undiagnosed diabetic patients. And we also took a bioelectrical impedance measurement of the body fat. And you can see 80% of the South Asian men had a percentage body fat which was higher than 25%, which is the upper limit for men, and 30%, 93% of women had a percentage body fat above 30%, which is what is regarded, less than 30 is regarded as normal. And the waist measurement, if you look, 66% of men had a higher waist measurement, and 80%, 73% of women also had higher waist measurement. And you can see that, the cholesterol, the cholesterol measurement. And if you look at the calculated cardiovascular risk, and you can see 10% of this population had more than 20%. And I have to say, we used the Q risk to calculate the risk. And if you look at the 10 to 20%, a significant number of people also had a high risk in the intermediate range. So it's a population which shows dyslipidemia, diabetes, higher percentage of fat, higher waist measurement, and a higher cardiovascular risk. Something which I really wanted to look at is, when do we tip off to become dyslipidemic, or when do we at what age do we start becoming a high risk group? We want to intervene at that age. So what we did was, plotted the body mass index in the age group, waist to circumference in age groups, and the HbA1c in age groups, and the dyslipidemia follows the same. And you can see that the 2029 to 30, that is the age. There is a steep rise, and we keep increasing it until the body mass index increases up to 60, and then we stop. And the same with the waist circumference, and the same with the glycated hemoglobin. And if I had a dyslipidemia graph, it follows the same, but it's difficult to plot it because the triglycerides can vary. It was a non-fasting sample, but I'm sure the dyslipidemia in general also follows the same. So this is between 20 and 30 is where we should start prevention. And it's, by the time we are 40, we're already there, and we may have already set in for cardiovascular disease. And therefore, probably what we need to do is to put programs where we can do something between 20 and 30, so that we teach them the non-pharmacological treatment, so that we don't have to use treatment, and we encourage them to follow that throughout till 60. That is when it would be. And I always think, because people get married between that time, they settle, income, and probably that's what makes them a high risk at that age. And this is a very recent one, where they looked at 121 first-generation Asian immigrants. And again, if you see the same principle, at around 30, we are tipping off, the South Asians, and compared to the other people. And the prevalence of obesity, again, it's very similar to how I showed you. So it's reflected in, comparatively reflected in other things. Diabetes in men and women, very similar to what I showed you. Between 18 and 13 is when it starts off. So probably this is what we need to do. Start them really young, catch them young and teach them. Probably start from the university age of teaching cardiovascular health, where we wouldn't have to spend too much on the drug, and we wouldn't have to deal with the complications of dyslipidemia and so on. And this is something which is well known, abdominal obesity and increased risk for cardiovascular events. And if you see the risk increases with increasing waist measurement, this is in the Caucasian population, but it applies to the South Asians too. So we also have lean mass. Lean mass is less in South Asians. So if you look at some of the historical data in a recent study of the skeletons spanning 11,000 years, what they said was that low lean mass is seen in the South Asian population compared to the worldwide sample. The stature of the South Asians decreased sharply when agriculture was adopted as one of our main way of living, while the stature adjusted lean mass increased to a minor extent over the time. The historical data suggests that the South Asian populations in the Mesolithic period were relatively taller than we are now. Since then, population may become increasingly undernourished for generations, and this may have become more pronounced. And we can blame the British colonization of the subcontinent may have done that. And that's one of the suggestions made in this paper. And these long-term intergenerational influences, especially those affecting the maternal and childhood during the first 3 years, may have an impact on the metabolic capacity in these patients and the development of diabetes and diabetes susceptibility. And we also know from many of the studies in South Asians, a gene encoding myostatin, a protein that inhibits skeletal muscle growth in utero through placental glucose uptake. And you may have heard about the Barker's theory of the thrifty gene hypothesis as well. So another form of ectopic fat deposition, accumulation of lipids within the skeletal muscle from ineffective lipid metabolism as a result of mitochondrial oxidation is also suggested in South Asians. So compared with the other ethnic group, you would see that there is a higher prevalence of isolated impaired glucose, which is primarily the result of hepatic insulin resistance and the impairment of the beta cell function. And again, referring to the Masala study, which compared to the where the South Asians were compared to the Caucasian population, we know that the abdominal visceral fat area and the hepatic attenuation, which means that more fat in the liver, were independently associated with glycemic progression and dyslipidemia in these patients. Hepatic fat was more closely linked to the progression from pre-diabetes and diabetes and the dysglycemia and the dyslipidemia, which has already begun. So if you again look at another study from UK, the Biobank data, the genetically predicted higher circulating liver enzymes, surrogate markers for the alcoholic fatty liver disease, increased risk for diabetes. So all this contributes to the difference in dyslipidemia with the Caucasians. And this is, again, we would call this an unfortunate composition. This is Yajnik and Professor Yadkin. Both of them, get BMI, you can see that 22.3, exactly the same. And the body fat, 21% for Yajnik, and for Professor Yadkin is 9%. And you can see that we are prone to accumulate fat, and also that is translated into the dyslipidemia pattern, which we see in our population. And if you did a CT scan, this is what you see: chalk and cheese in us, whereas in a patient of Caucasian origin, we see very little fat, but we have a lot of fat in our abdomen, which is causing the dyslipidemia, the atherogenic dyslipidemia, the endothelial dysfunction, which gives us the prothrombotic state, all the hemodynamic changes, the pro-inflammatory status we have, and all the associated factors. So there is a genetic foundation. We have to say the culture, the collectivism, prioritization of academics and familial duties, culture-based stress. We cannot take away all that, both in the migrant population as well as people who are living in the South Asian countries. This is very, very important. Less physical activity, thrifty gene urbanization, sedentary occupation, and the diet, especially causing the dyslipidemia. And you look at some of the data will point out towards the Barker's theory of undernutrition or overnutrition, which is leading to think probably undernutrition is more or less the reason for the increased dyslipidemia and the increased body fat we see in the patient. If you look at the ethnic difference in the
Excuse me,
cardiometabolic
Dr.
risk
Nair,
factors,
the time is over. If you can finish in another 1 or 2 minutes, that would be helpful.
Thank you. At the age, if you look at the children, again, the children born have intra-abdominal fat increase and they have triglycerides, even 9 to 10 years have a higher triglycerides. And this is the diet, carbohydrate rich, and you can see the 2-hour glucose levels in a diabetic. I come from South India, and therefore I know very similar to the Sri Lankan diet, and you can see we do eat a high thing. And again, you can see that the family history or positive and family, and if you're sedentary, you have a 3 times higher risk for developing heart disease again, and the dyslipidemia. So one of the problems is lack of social and family support, major factor in maintaining the diet. Any functions we eat, and this is something part of our life. And the patients also transfer the responsibility of the healthcare to the healthcare professional, and we do have communication with the healthcare provider being sick. And what we need is simplicity. And I just thought I put this slide up just to say that probably a simplified risk calculator, simplified management of risk factors is what we need. And we cannot separate dyslipidemia from other risk factors. Prevention should really be simple for countries like India and Sri Lanka, where primary care physicians at the desk can make these decisions. So Professor Mendes is right in saying that the risk calculator has to be simple and be available for use in primary care. Thank you.
Thank you, Dr. Devaki, for your interesting lecture. Our next speaker is Professor Naval Vikram from India. He is going to talk to us about obesity, how to tackle in the clinic. Over to you, Professor Naval.
Thank you, sir. First of all, I would like to thank Sri Lanka College of Internal Medicine for giving me the opportunity to speak in the conference. It would have been wonderful to be there physically, since I was there a long time back. So I'll share my screen now. So is my screen visible to everyone?
Yes. We can see, yes, Professor.
Okay. So after the 2 wonderful talks, my job is to talk about how to tackle obesity in the clinic. We all know that obesity is a complex, chronic, and a progressive disease which has numerous health complications which affects almost every organ of the body. Now, the factors which influence obesity, though the behavioral factors are the most important, however, the heritability of obesity ranges from about 40 to 70%, and a lot of genetic studies and genome-wide association studies have been done, and it has been shown that about more than 300 loci have been identified, which may contribute to the development of obesity. So, as it is a complex problem, the management also is a little complex, and the management has to be structured, individualized, and multidisciplinary. So, managing obesity in a busy internal medicine clinic of any hospital or any medical center may not be effective because this requires a lot of time, discussion with the patient, counseling of the patient, and that is why it's better to have a specialized clinic where these patients can be seen and managed by a multidisciplinary team. It's important to understand what is the cause of obesity, because the cause of obesity is, to be simply putting it, is that a person is eating more and walking or exercising less. I mean, it's not as simple as that. This may apply to some, but may not apply to everybody. And that is why cause of obesity is important to know. And how does it affect the patient? Because the influence of obesity may be different on different patients. It's also important to understand what are the barriers which are perceived by the patient as well as the healthcare providers in effective management of obesity. And based on these, patient-centered plan has to be formed and with a predefined goal, so that there are long-term benefits and lifestyle changes which are sustained over a period of time. So the dimensions of obesity management would be 4 major aspects: the nutritional aspect, the physical activity, behavioral or psychological, and pharmacological. So I'll briefly discuss about each of them one by one. So if you want to set up an obesity clinic, now this has 3 major components. One, the team, the personnel which are required out there. Second is the equipment, and this can depend from center to center, on how much resources are at your disposal, and then the process. Now, the team primarily should consist of a clinician, and nutritionist, exercise therapist, a psychologist or a behavioral therapist, and technician and a support staff. And of course, whenever required, in consultations would be made from a bariatric surgeon. Now, this is applicable possibly to a setting with good resources, but in the resource-constrained settings, the clinician or the physician has to play an important role and has to take over the part of a nutritionist or an exercise therapist or a behavioral therapist. So all of these roles may have to be played by a physician where these specialists are not available. Equipment, the first one I'm sure would be available in any obesity clinic, the weighing balance, stadiometer, etc. If you're more resourceful, then body composition analyzer or a muscle strength tester may be also may be used, and other instruments like a FibroScan to assess the liver stiffness or a whole body DEXA scan. So it depends on how much resources are at your disposal. Now, the workflow in obesity clinic should be when the patient first comes in the contact, the first thing is to do body measurements, that is anthropometric measurements, body composition analysis if feasible, and the muscle strength or the hand grip strength. So because these will have an implication on the kind of management that you want to offer or the kind of advice that the patient has to be given. Next is the interaction with the physician or the clinician, where thorough history, a detailed examination is done, and to detect or the presence of any coexisting other disease processes which may also need to be managed simultaneously while giving a treatment or managing obesity. And after that, the next part comes the counseling, where the nutritional, psychological, and the physical activity or the exercise therapists come into action, and they offer their advice and evaluation, biochemical evaluation on evaluation for the comorbidities or lab evaluation, whatever has been as advised by the physician, and subsequently a follow-up. So this is in brief the workflow of an obesity clinic. Now, grading versus staging. So most of the interventions which are designed are depending upon the grade of obesity, which is grade 1, 2, 3, depending on the BMI. But this may not always be an appropriate way of managing obesity, because there may be other coexisting problems, psychological symptoms or functional limitation, which also have to be taken into account. So I think this Edmonton obesity staging system, which was given quite some time back, summarizes this very beautifully into the 4 stages. So depending upon the various medical, mental, or functional impairments. So one patient can fall into a grade of obesity, and in that grade of obesity, that is at BMI range, the patient may be in any stage depending upon the presence of comorbidities, and accordingly the management of that patient has also would also differ. For example, a grade 2 obesity patient with stage 0 may require a different management from a patient who is grade 2 and stage 3. So staging the obesity along with the grade would be appropriate for appropriate management. Now coming to the 5A, the most commonly used approach for obesity management, the ask, assess, advise, agree, assist, or arrange. Now ask, it's very important to find out what is the awareness of the patient, what the patient knows about the health risks of obesity and the benefits of weight loss. So this is very important to find out what information the patient has. Showing empathy and being non-judgmental is very important. That helps to build rapport with the patient. Because if the patient senses that the physician or any person in the team is judging the patient or accusing the patient that you are responsible, then their patients are not forthcoming, and you start to lose their cooperation. Now, patient's readiness, motivation, and confidence to lose weight is very important. How ready is the patient and how motivated is the patient? That will help you in setting up goals, short-term goals as well as long-term goals. And that is going to tell you how much are you going to achieve over this period of time. Finding out about the onset and rate of weight gain is important, because sometimes there may be some life event. There may be, suppose a post-pregnancy, suppose a person has some mishap in the family or something, or even a chronic smoker has quit smoking, and after that the patient starts gaining weight, which is quite common. So what is the life event which has started this process, and how rapidly or how rapidly the person has been gaining weight? So this will give you an idea how to plan weight loss therapy ahead, and what the patient has done before, how many attempts the patient has made about this problem of weight. So if the patient has tried losing weight earlier, what was the success and failure? Because that will tell you what you don't have to do now, because something which was done earlier, the patient had failed that attempt. So you don't have to do that. You may have to do something else. Otherwise, if you advise the same thing, the patient is not going to cooperate with you. There are several barriers as well as motivators for weight loss, and these need to be discussed with the patient. Now, assessment is a key component. Now, assessment involves a lot of things: assessing the clinical assessment, body composition assessment, nutritional assessment, and assessment of comorbidities, and along with that you assess the root causes or what are the drivers of weight gain. So components of assessment mainly include, I have briefly put it here as A, B, C, D, E, and F. Now, A is the anthropometric measurements and body composition. B, the biochemical assessment. C, the clinical evaluation and comorbidities to look for the presence of other disorders. D stands for dietary or nutritional assessment, or what has been the change in the nutritional profile of the patient, which might be responsible. E is the exercise, the physical activity status. Now, I have added an F here because now this fatty liver or non-alcoholic fatty liver disease is something which almost all the patients will, several of these obese patients will come to you. They might have done an ultrasound for whatever reason, and there it comes a report as grade fatty liver is seen. So this concerns them. So they always will come with this. So assessment for the presence of fatty liver can be added as another component of the assessment. Now, anthropometric assessments, as I mentioned earlier, you need a simple instruments to do most of the assessments like body mass index or circumferences and body composition analysis if you have an access to bioimpedance or a DEXA scan. Biochemical assessment is to look for the presence of comorbid, the assessment of metabolic abnormalities which are there, dysglycemia, dyslipidemia, or any other organ system or organ dysfunction. And hormonal profile may be done depending upon what you're suspecting. If it's a patient, a history suggests, maybe thyroid profile can be done. In a female patient, if there is if the patient has history which is suggestive of polycystic ovary disorder, you would like to do other hormonal levels as well. Now, dietary and behavioral assessment. This is very important. It's important to know what the patient is eating now and why the patient is eating this. Why is also very important. This can be done using a 24-hour recall or a food frequency questionnaire by a trained dietitian. Now, it's important to identify the dietary habit of an individual and assess if there is any unhealthy eating behavior. So you may have to find out the unhealthy behavior so that that can be specifically targeted when you are giving an advice to the patient. Now, there may be some factors, as I mentioned again, factors or life events which might have triggered these unhealthy eating patterns. Like and the unhealthy eating patterns have probably become even more during these past 1.5 to 2 years because of several lockdowns, lack of movement of people. So during that time, some of these behaviors might have also developed. So what are the life events or the triggers that need to be targeted? Evaluation for undiagnosed psychiatric comorbidities is very important in these patients because these psychiatric comorbidities may not only be the cause of obesity, but may also interfere with the management of obesity and the quality of life. So this was a study that we recently published. It was, we saw the prevalence of psychiatric comorbidities in patients, about 151 patients who had BMI more than 25 kg per meter square, but none of these patients had coexisting psychiatric or any metabolic comorbidity. That is, they did not have diabetes, they did not have dyslipidemia, they did not have coronary artery disease. They just had a BMI of more than 25 kg per meter square. So one can say that they were probably metabolically healthy obese. And they were screened with the mini screening tool. And what we see here is that about 24% of the individuals had at least lifetime diagnosis of at least one psychiatric disorder. And overall, the prevalence of depression, major depression, was seen in about 18.7%. So almost 1/4 to 1/5 of these individuals had at least one disorder or major depression. Now, if this is undiagnosed or if this is not taken care of while managing the patient or while counseling the patient, this can interfere with the the management of appropriate management of patient and also the patient's ability to lose weight subsequently. Now, the role of coming to advise, the dietitian has a very important role because one has to provide a customized, mutually agreed upon diet plan as per the nutritional requirement and choices. So the key words are mutually agreed upon, nutritional requirement, and choices of the patient. Because something if is not according to the choice of the patient, then it's unlikely that the patient is going to adhere to this diet plan for a very long time. And this is particularly important in resource constrained settings, or if you are dealing with patients who belong to the lower or lower middle socioeconomic status. So there, these patients may not be able to afford your meal replacements or other therapies. So there it is very important that within their choice or availability of food items, whatever they have. So within that, how do you plan appropriate diet plan? And that is very important, and that sometimes can be challenging as well. Now, calorie restriction is the most important aspect. Now, calorie restriction, generally it is agreed upon that it is 500. Low calorie means that you restrict the calories from 500 to 800 kilocalories per day. More severe restriction, very low calorie diets or other forms of calorie restriction may be advised depending upon the acceptability or requirement of the patient. But calorie restriction is important. What form of restriction, the calories, what form of diet may be given, maybe the component of diet, that is low carbohydrate, low fat, that depends upon what are the coexisting comorbidities of the patient. But overall, it has been shown that whatever type of diet you give, what matters most is the calorie restriction. So that is the most important aspect. Portion size reduction and meal replacements may be advised if it is feasible or if it is affordable by the patient. And along with this, monitoring of the adherence and reinforcement for the same is more helpful in achieving appropriate weight loss. Clinician's responsibility is to re-emphasize about the role of diet and physical activity in management, because a patient is more likely to listen to advice of a physician rather than a dietitian or exercise therapist. So if physician says the same thing, the patient is more likely to listen to that, adhere to that. Pharmacological treatment, it depends upon what are the choices of drugs that you have in your armamentarium. Although there are 4 or 5 drugs which are available, which have been approved for use of obesity, but as for India is concerned, we only have as of now Orlistat and liraglutide which are available. The other drugs are not available in our country, and even these drugs are quite expensive, and they are not affordable by a large majority of the patients which I see in my practice, because most of them are from the middle or lower middle socioeconomic status. So wherever feasible, these drugs may be used. Along with this, if there are coexisting abnormalities, so the choice of medications has to be made in such a way that none of these medications aggravate the problem of obesity. Surgery may be advised wherever feasible, and post-surgery care is also the role of a physician. Now, behavioral therapist or psychologist also has an important role. So their strategies for behavior change and overcoming barriers have to be planned and discussed with the patient. So what has to be encouraged is the self-monitoring. So self-monitoring in the form of making a food diary and exercise diary. So these go in a long way in empowering the patient himself or herself that to keep a note of what the person is eating or the person is exercising. So this encourages them that to adhere to the advice which has been given. And one need to find out what are the good habits and the bad habits. And one has to further advise to avoid the bad habits and go on or continue with the good habits. So controlling the stimuli also forms a part of this. Potential sources of stress need to be identified because stress is a very important factor which leads to all kinds of problems, and also it's responsible for obesity. So identifying any coexisting psychiatric illness and appropriately managing that is important, and is a very important role played by a behavioral therapist. Exercise now is an important aspect, but the prescription of exercise needs to be individualized. Now that needs to be done depending upon the physical capability of the patient, and a tailored exercise plan needs to be made. Now, a combination of aerobic and a resistance exercise. So why I'm emphasizing on the resistance exercise here is that many of these obese patients also have sarcopenia or low lean body mass. They have excess fat that itself is causing a problem, but the low lean mass also is an important reason which may be associated with the coexisting metabolic abnormalities. So with any kind of weight loss program, there is also a decrease in the lean body mass. So resistance exercise has to be added, and because this not only improves the muscle strength, but also it preserves the muscle, because it decreases the lean body mass. Decreases the loss of lean body mass in the setting of weight loss, and it also improves functionality. So if functionality improves, the patient is able to exercise more, and that is why resistance exercise has to be an important part of the exercise plan, which should be progressive. Depending upon how much the patient is able to exercise, it should be gradually increasing in the intensity and gradually increasing in the duration, and it should depend upon what are the resources that the patient has an access to. If the patient has an access to a well-equipped gym, that's great, but which may not be the same with many or most of the patients who are coming. So they can be advised exercises which can be done by them using simple objects, and they can be done at home. A simple objects just like elastic bands or elastic loops, and the exercises with these can be done at home also. The next important component is agree. So after you have given the advice about the weight loss, a plan should be agreed upon in consensus with the patient. So if you say something, the patient is not agreeing, it's unlikely that your plan is, more likely that your plan is going to fail. So what you have to agree with the patient. If the patient says, okay, I am not ready to start the things right now, you agree with the patient. You say, okay, we can start, have a time limit, we can start after this time. And you set a goal. Setting a goal has to be specific, that it has to be how much you would be losing over this period of time. It has to be measurable, right? And it has to be achievable. So setting goals which are not achievable is more likely to lead to failure of your advice. Relevant, the plan should be relevant, that you cannot have irrelevant plan like setting some fantasy goals, and which the patient you would think that if I give this advice, the patient is likely to do that or achieve that, but the patient does not think that he or she would be able to achieve that. So a relevant and time bound. So SMART is the acronym which can be used to set the goals, and it has to begin with smaller targets as opposed to giving a big target at the beginning, like at the end of 6 months, at the end of 1 year, I want you to lose 12 kgs or 15 kgs. No, that should not be one. It should be 3 months. Start with smaller targets for a smaller duration initially and gradually build up over a period of time. And pharmacotherapy, of course, if patient accepts it or if the patient is able to afford it, can be added.
Professor Vikram, your time
Now,
is up.
okay, this is my last slide, I think. Yeah. So last one is assist and follow-up. Regular follow-up is imperative in identifying and modifying successful approaches. And regular consultations and ongoing support is very important. Many studies have shown that intensive counseling up to six face-to-face sessions over a 6 months period are much better, or even more sessions have result in the greater patient motivation and weight loss. Use of technologies like fitness trackers or pedometers, which are very common in many digital or many smart watches available, may be useful and objectively track physical activity, which may enable the patient to or encourage the patient to continue with that with physical activity, and involving family members and the work associates is very important to decrease or get over the obesogenic environment which may be there at home as well as the workplace. And social and patient support groups may be created, and this goes a long way in increasing the adherence to the given regime. So in summary, management of obesity is not easy, and it requires a dedicated multidisciplinary team of professionals and a structured management plan. But wherever you don't, in a resource constrained setting, a physician has to play the most important role and advise regarding lifestyle changes. Evaluation should consist of not only physical evaluation, presence of comorbid illnesses, body composition, and assess the psychological or the behavioral aspect as well. Now, individualized nutritional plan, exercise plan, as well as behavioral modifications and reinforcement go a long way in managing obesity appropriately. And with that, I'll end my presentation. Thank you very much.
Thank you very much, Professor Vikram, for that very informative lecture. As we are running behind the time, we would like to limit the questions to maximum 2. We would like to entertain any questions from you if you have. Actually, I have a question for Professor Shanti Mendes. Madam, it's regarding the total risk approach implementation in Sri Lanka. I am involved in like guideline development and training programs. Most often, I find it difficult to convince the fellow physicians regarding use of WHO ISH risk prediction tool. Their main concern is that it underestimates the risk in our population, like in comparison to tools developed for other populations like US ACVD risk calculator and Framingham. So how should we respond to that?
Thank you very much, Madam Chairperson. The response, firstly, is I think you could also bring to their attention that the 2019 risk charts are very much more accurate, and the estimation would be very much more true to reality if you use the 2019 charts instead of the WHO ISH 2007 charts. This is one. Second, in another way of thinking, if any person wants to in their clinic use a different tool, different risk chart, even that is better than not using any. If they want to recalibrate another chart like the Framingham, or there are so many like 20, 30 different risk prediction tools that are available. So they don't necessarily have to use the WHO charts, although they are, I would say, compared to any other chart that's available, 2019 charts are much more accurate.
Thank you very much.
I hope that answers your question.
Yeah, there is one question from the audience.
My question is to Prof. Mendes. Now, with increasing burden of NCDs, we see a lot of young patients affected with NCDs. So what is our approach in clinical practice for patients who do not fall under this risk scoring system? Most scoring systems start from 40 years. when we encounter younger patients, what should be our approach?
Yes, so the younger age groups are not included in the charts. Thank you for that question. It's an important one because there are no data for us to really do a worthwhile calculation. The data are limited to those above 40. But yet, the few patients that you see under the age of 40, you could still apply the chart, but then also recognize that whatever risk you come up with in the calculation is an overestimation. And that is really the best that you can do at the moment. So you use the charts available, but when you use the chart, the age category, say, does not go down below 40 or 30. You still use the youngest age bracket, but then the risk that you assess is a slight overestimation. But you can still communicate the risk to the patient in a useful way. And also your decisions can be based on the risk, because oftentimes these very young patients are either diabetics or borderline elevated risk factor levels they might have. Thank you.
So we will close the session as we have run out of the time. Again, I would like to thank all three speakers on behalf of the Sri Lanka College of Internal Medicine for their committed, the very informative lectures and their commitment. Let's show our appreciation in the usual manner.